Now you are able to see the slides.
Yeah, we can
So
see your
good evening,
slides. We
everyone,
can.
all the teachers, chairpersons, panelists, and my dear friends. This is actually with the more intervention what we are doing now. It's a good coordination between adult cardiologist and the pediatric. Now they started calling us for taking our help in doing the post-MI. So we are also getting little bit tuned in treating post-MI VSR. So this I thank Dr. R.K. Jain, who give all these slides old, which when I was not there in the experience in the KIMS and what I involved with 8 or 10 cases with them. So why post-MI VSR are peculiar and difficult to attend because it's evolving. Whenever we are doing the acute, it's evolving it. Whatever we do beyond that also, it may evolve and cost in a very friable margins. So it's a very dangerous to do, decide the size as well as it's a very hemodynamic unstable. And all those patients are LV dysfunction, pulmonary edema, renal failure, comorbidities are very one of the most dreadful substrate to do the device closure if at all it's indicated. Altered and fragile hemodynamic, this is one of the most important point. In spite of doing everything, there is a very high morbidity and mortality. This is the combined effect, two brains, adult pediatric with sharing the whole responsibility. It's a good thing that both are coming together and giving some good results with that. So just a little bit, it's a 1 to 3% without thrombolytic therapy, with more common in female. One vessel is present with 50% and with three vessels present in 10%, and very high mortality and morbidity in spite of doing that. So this is just the theoretical ki first hyaline degeneration, then enzymatic degradation, fissure formation, and the septal rupture. This is the Becker classification. There shows two types, Becker 1, 2, 3, where it's a free wall rupture, and then when it's a ventricular septal rupture, it may be simple or complex. And two things, it's may present a bimodal presentation like occurring within hours or within 3 to 5 days or even later after the index MR. So these are the two. This from net I got because I am not having some of the old pictures, so I'm able to get it. So these are the two types. Type 1 is the simple, where it's a simple punched out defect, but type 2 the serpiginous, where the crossing is difficult and the more hemodynamic instability and chances of failure. So the other two things, the LAD and RC are the most common infarct. Entry infarct results in apical VSR, while inferior that is result in more complex and more basal, that is more challenges and having the more problem. And the RCA, its involvement of the more free wall. So sometimes the two of the instances when adult cardiologists found after 3-4 days, and when we started, we saw it already evolved into the frank ventricular aneurysm. So we have to send for surgery. So what we saw today may not be applicable for tomorrow or day after tomorrow. That is the typical example of the post-MI VSD. So increased likelihood of developing all these adult thing, but just because of the little bit I can tell, older age, female, prior stroke, higher heart rate, Philip class with the which is the classification for the failure and delayed and lack of pulmonary perfusion. This is one of the most important sites. We have no European Heart Journal from 2014. If what is the natural history of acute MI with VSR at what intervention? So immediate there is no data. But when you do within 60 hours, still the 60% mortality will be there, and only 60% survival, 40 to 50% mortality. And once the 30 days survived after 2 weeks, and then there is no attempt, in spite of that, there's a 94% the survival rate. So we have to see once it reaches up to the 2 weeks stage where it survives, there's very high chances of survival even without doing anything. You have to treat the coronary. So this is just the small flow chart, hemodynamic unstable acute with immediate surgery or percutaneous procedure if anatomically suitable or unlikely for surgical candidate, or hemodynamically stable with large VSR, close monitoring with afterload reduction, and then we have to decide whether ECMO or delayed surgery. And when it's a stable, it's a onus is on the surgeon as well as on the cardiologist team to decide whether you want to do or send for the elective surgery. Acute phase mortality is 60%, but after 14 the mortality is 24%. So the challenge is just 5 minutes. It's a low cardiac output, ventricular dysfunction, multiple lines will be there, IABP, LV injection. So given or not, as a protocol, we are not giving LV injection. Snaring with introduction of the sheath, that is the main point of the destabilization because it's already akinetic segment. Once you do, there's a drop in BP. So in most of the cases, when we are putting the sheath, there's a transient hemodynamic and instability. And assessment of VSD again after doing that is one of the again important thing because it's never start. So in short, decision of taking for VSR closure itself is a challenge, and these are all challenges we have to take care of. So comorbidities detection in presence of surgery, device closure done, assessment. So it's a continuous process going on because it's in the lower elder age with a lot of comorbidity. Imaging is crucial. Nowadays, we 99% it's done with the imaging only. So with the 2D echo as well as the T images, you can see there is a mid muscular, little anterior apical, And these are the few pictures that shows it's a basal, which is one of the contraindication because it will impingement of that. But still, we went ahead with the two. The immediate improvement was there, but later after 6 months, one of the patient found to severe TIA has to undergo surgery for the tricuspid wall repair. So this is the one just to show IJV electively we are taking because these are the all mostly in the muscular septum. So it's a better to take IJV and the TE test because we are not doing the LV angiogram. So few rules we follow: no angiogram injection, only echo-guided bearing, few exceptions, one or two where we are unable to cross after long time. Cross wire, when we cross the wire, we have to protect it with the catheter so that it will not tear the VSD. Mostly with IJV approach, oversized defect will do minimum 8 mm because it's a fragile and it's a evolving. And device introduction with intact AV loop and AV loop with the wire with the buddy wire technique follow up closely for hemodynamic even after that. So this is the first case that shows the IABP and that we took the IJV line, the excess IJV value, and sometimes once you do it will able to cross with the IJV approach only, so no need for AV loop, so we can avoid the hemodynamic instability. These are the some of the principles which is same for the VSD what we are doing, but when adults are doing, they're not much more that, so they took our help and we combine both of our knowledge to give the good result. So this is like the typical crossing without angiogram. We are just crossing on the echo basis only. And this is the few of the things. See the second, the loop is very unstable. Then we have to go with the IJV, we have to break loop, and with the wire we push the sheath and the device so that even if it fall back, we can able to form the device. And that is the post MI VSD muscular what we use. So this is the one of the case where it's successfully done. This is the loop which becomes unstable and we are unable to put the sheath. So that again we have to break and do it. So with that, there is a lot of hemodynamic stability. And one patient, while we are doing it, got ventricular rupture and died on the table. So you can understand, even if you are dying, it's a very high risk in that case because the ventricular rupture may happen even during the procedure also. And this is one of the thing because it's why the VSD, particularly post MI, there is a long length of the waist. So you have to push to make it happen. See, because there is a long segment and there is an aneurysm, so it will not form. So you have to daughter to make it form happen so that it will accommodate in that. So this is from the femoral root because we're able to do, but there is a sheath thing because we took non-braided. So as a routine, we should take the braided sheath. This is one of the more clues what we have to do in this case because we will not get the time. This is one of the patient where you see the second, the alignment when we did from the femoral, it all prolapsed. So we took little bit more and we put from the IJV for the better alignment that we are able to do that with this. This is one of the patient where we did the 26 mm. So we put the 30 mm ASD occluder so that because about 24 the post MI VSD occluder is not there. This is one of the case where we are able to do it with the IJV. And but this is that. But this is the our previous exercise where we used to give some injection, but from the last 5 years we hardly give injection for the only one case. The advantage of post MI is the length of waist is 10 mm with the 16 to 14 size available, and we can go. And you can see the beautiful images of the echo where with the echo will deployed and without giving any contrast injection. So this is the sheath which got kink and got kink, but we able to make up the good loop and then we'll able to do it that. But with that there are some complications also. This we tried 2-3 times and then after that the rupture happened and the patient we lost within 24 hours. He's a 70 years old. And this is the VSD expansion. Even after closure, there will be VSD. And then with the VSD expansion, there is the embolization of the ASD and the patient died after 6 hours, even after surgery. So you can see this is not the simple. And then the severe LV with the hemodynamics not improved because once you do, you have to see the hemodynamics. Once with the VSD closure, hemodynamics improved, that means it's a useful, otherwise it's not useful, whatever it is just for the cosmetic reason. So these are the some of the problems. And sorry, it's not. So this is even after that, you see, after 6 days, we find again large shunt, and this patient developed the ARDS and died of the COVID during this time. And this even after doing the IABP, there is a rupture of the artery. So this is that 70-year-old which caused, and this is our experience in KIMS where this is the 11 cases before and the last 6 cases with total 18 cases, 2 we are unable to do. And then this is the total survival, where in KIMS till 2015, our survival rate was 35. But from 2020, the survival rate is 60%. And the last 5 patients, 3 died because 1 died on table with the rupture and 2 died because of the ARDS developed. Even after that, it did not improve. So contraindication last 2 slides is more than 35 mm defect with apical VSD without trim, basal VSD, and post MI. The problem is it will not come before about 24 mm. And when you use the ASD, it will go at a dumbbell and won't form the properly until it sets in the aneurysm. So complication, failure to perform, hemodynamic deterioration, malignant arrhythmia, and the LV rupture and embolization measure we had all, because one patient died because of the VT, one died of rupture, one major respiratory shunt was there and not improved even after 10 days, and divorce embolization due to that. So last, there's the 11 commandments: avoid inferior MI, do limited coronary. Main pathology is mechanical problem, you have to just correct it. Try to avoid LV angio because it itself will tilt the balance. Take braided sheath, keep wire before release. Low cardiac output, doing LV angio, you will worsen the renal function and the cardiac output. Heart team approach, and team approach should intervention cardiologist, and systematically refer these patients to centers with good experience would have VSDR present. So we are still evolving. We don't know whether we are doing right or wrong, but we are doing it judiciously, keeping everything and able to do that. So I thank everyone. And there's a mammoth talk taken by the everyone, nursing staff, radiologists, adult cardiologists, everyone. So it's a combined effect, and now we are able to get up to 50% result. But long term, we don't know after 5 to 6. Out of these, only 3 patients come up to 3 years, 5 years, and 7 years. Rest, we don't know whether they survived or not. So with the pinch of the salt, there is one saying what our teachers used to say: whether you do it or not do it doesn't matter. You have to just maintain the hemodynamics. Once it reaches up to 2 weeks, you will able to do with the good result with the surgery. Until it's you are forced to do it. So thanks a lot. And this is our what this is the X-ray book we wrote, me and Neeraj, with the around it's a 3,000 X-rays with from the congenital to the intensive care, ECMO devices, stent, everything, with the help of Subramaniam sir and the Radha sir. So thanks a lot for your kind listening, and good to see you all after a long time. Thanks a lot. I'm ready for the questions. Anything from your side?
Thank you, Sudeep, for the wonderful